Good morning, my name's Drew Cronin. I'm a plastic surgeon here at the Coastal Clinic on the Gold Coast, and I thought this morning I'd take the opportunity to do a slightly longer form video for patients that are considering coming to see me for bilateral breast reduction surgery. Breast reduction surgery is a very common procedure that we perform in plastic surgery, and it's what we would think of as one of our happier procedures in plastic surgery. It's an operation that consistently has the highest ratings of patient satisfaction after surgery. And there are a number of reasons for that. Typically when patients are considering breast reduction surgery, they've been encumbered with macromastia or large breasts, sometimes for many years, sometimes for their entire adult life. And they may have symptoms such as grooving in the clavicles, back and neck pain, shoulder pain, rashes underneath the folds, sometimes difficulty finding and wearing normal clothing, undergarments, swimwear, and they feel like their large breasts just make all aspects of their life that little bit more difficult. Obviously exercising and running, going to the gym, swimming, but even just doing their normal activities of daily living. Breast reduction surgery is an operation that can quite effectively relieve all of those symptoms, or the vast majority of those symptoms for patients, but also the recovery from the operation is typically not particularly onerous, and so it's a low hurdle for patients to jump over in order to get significant symptomatic relief and improvement, with the aesthetic benefit of often looking like a much more youthful breast that the patient once had. When I ask patients what problems they have with their breasts, they typically would say, well, they're just way too large for my frame. But a slightly more nuanced answer would be that there's three issues with most of those patients' breasts. Now, the first is that there's an excess in vertical length of the breast coming down over the fold and onto the upper abdomen. The second issue, which patients may not always be aware of, is that there's an excess amount of skin and breast tissue from the medial-most aspect of the breast all the way out to the lateral-most aspect of the breast. And typically patients would be aware of that if they lie flat on their backs without bra support on, that their breast would have a tendency to fall out into the axilla. And the third issue is that the nipple areola position on the breast is sitting far too low on the chest wall or on the breast. And for some women, particularly those that have had children and breastfed, that the nipple areola complex may have stretched out during breastfeeding and then not retracted back. And this is an operation that's able to address all three of those concerns in the one procedure. One of the common questions about breast reduction is, what size can I get down to? Well, sometimes patients will come preloaded with an idea of what bra size would be their goal after that operation. And I always ask patients about that in the consultation to give me an idea as to whether they're someone who wants as much breast tissue as can safely be removed, taken out during the procedure, or for someone who just wants a small or more modest amount of breast tissue and skin removed and still having the lift and the reshaping component of that procedure. But it's a little bit of a trick question, because to an extent, the final volume of breast in cup size is largely determined by the height of the patient, the width of their shoulders, the size of their breastplate. And so for someone who's taller and broader shouldered, more athletically built, the final breast size may still be slightly larger than someone who's more petitely framed. Ultimately, the goal of a breast reduction, and where I think the best results in breast reduction occur from an aesthetic point of view, is when you're trying to ultimately create a breast that is the width of the patient's chest wall, the height of their chest wall, has a natural and normal sort of aesthetic and curve that ends at the fold with a nipple placed on the front. But for most patients, that typically falls somewhere between a B cup or maybe up to about a D cup. There is the occasional patient that you'll see that will have significant gigantomastia, wearing a cup size like a J or a double J, where the limitation really is how much you can remove, is how much you need to leave behind in order to keep the nipple alive. Now, one of the common misconceptions with breast reduction is that once you've removed the excess breast tissue and the excess skin, when I'm marking up a patient preoperatively for a breast reduction, and this is something that's performed in the anaesthetic bay before heading into theatre with the patient standing, I will mark the midline or the meridian of the breast all the way through the nipple and down onto the top of the upper abdominal wall. And then the first part of the first of the three issues with the breast that I'll address is how much excess skin and breast tissue there is in a left to right dimension. And I'll do that by pushing the breast out laterally onto the chest wall until the lower medial curve of the skin of the breast is nice and tight. And I'll draw a line from the new nipple position straight down onto the upper chest wall. And when I let go of the breast and it relaxes, that line will flow back towards the midline. And then I'll do the same in reverse. I'll pull the breast in medially until the skin on the breast out laterally is nice and tight. Then I'll draw another vertical line from the nipple straight down. And when I let that relax, that will swing back out laterally. And what we'll have are these two divergent lines that if all of the breast tissue is removed from between them and those two lines are brought together to make one single vertical line down from the nipple to the fold, the skin will be tight medially and the skin will be tight laterally. And I'll typically leave the length of those lines at between 5 to 7 centimeters, depending on the final volume of the expected breast after the breast reduction. And the reason for that is that we need a tight line of skin from the nipple down to the fold in order to create a final result of a naturally sitting breast. For some patients, they may already have a distance from their nipple to the fold of 10 to 15 centimeters. And if I'm lifting the nipple position up another 5 to 10 centimeters, that could lead to a final distance of 10 to 20 centimeters of skin from the nipple down to the fold. And so we need to remove some of that excess upper skin. I'll then connect the tips of those vertical lines to the medial part of the fold and then to the lateral part of the fold. And with that design, you can already appreciate the amount of skin that's going to be left behind and therefore how much has been removed. And that's called the wise pattern scar technique. Now, one of the big misconceptions with breast reduction surgery is that all of the breast tissue underneath that line is removed and then the nipple is taken off and stuck back down onto a different part of the breast. Now, if you take any part of the human anatomy and cut it off and stick it somewhere else, it may struggle because it doesn't have a blood supply. So what we need to do in order to keep the nipple alive, and ideally to have sensation to the nipple as well, is to leave a cuff of breast tissue around the nipple called a pedicle. And depending on how big that pedicle is or how big we choose to make that pedicle, that will largely determine the volume of the breast after the breast reduction. All of the skin is removed off the breast from that breast pedicle. If need be, the areolar diameter can be made smaller for patients that have a naturally very wide areolar diameter. That typically happens for most patients because ultimately a smaller breast deserves a smaller nipple. That pedicle of breast tissue is then rotated up so that the nipple sits in the space that we've created for it on the chest wall, and it is sutured into position then. After the nipple is sutured in, those two vertical limbs of breast tissue are sutured together to make one vertical line that goes from the nipple down to the fold, and those two lines attaching to the medial and lateral parts of the fold then become one continuous line that gets sutured down onto the fold. And that's called the wise pattern or anchor scar. And it's the only scar technique that can move and resize the nipple areolar complex, reduce the excess width of the breast, both with skin and with breast tissue, and also, and most importantly, remove the excess skin and breast tissue in a vertical dimension, which is the primary concern for most patients that are considering breast reduction surgery. All of those incisions are sutured with 2 layers of stitches. They're all dissolvable and sit underneath the skin. They all dissolve over the course of about 12 weeks. At the end of the case, no drains are required in breast reduction surgery, and a simple sterile tape is placed along the incision on the fold and another coming up the vertical incision and going around the nipple. And then I place you in a post-operative compression garment. Now, that post-operative compression garment, think of it like a cast for a broken bone. If you have a broken bone, it's set in a cast for 6 weeks because over that 6-week period, the bone will have the ability to fuse back in the position that we want it to be in. But also for someone with a broken bone, it's far more comfortable for it to be in a cast than for it to be not in a cast. And the compression garment is very similar. It holds the breasts in the position that we want them to stay in so that all of that internal scarring has an opportunity to occur over the course of the first 6 weeks. But it also makes the post-operative recovery much more comfortable for the patient because it is bearing the weight of the breast that's been left behind and not the incisions that have been formed. Breast reduction typically takes between 2 and 2.5 hours. Patients will wake up in recovery wearing their post-operative garment, and they will be wearing that pretty much 24/7 for the first 6 weeks after surgery. For that reason, we give you two of them, so one can be worn and one can be washed, and typically one is dark and one is lightly coloured depending on what you're wearing in your wardrobe that day. Obviously it comes off to have a shower, everything can be dried, the tapes can get wet because they don't get soggy, and then the garment can be reapplied. Breast reduction surgery typically takes between 2 and 2.5 hours, and the vast majority of them are performed as day procedures. Patients will go home with a script for antibiotics which run for 5 days after surgery, which is very much prophylactic to avoid any opportunistic infection from the bacteria that are resident on the skin, and a script for a stronger pain relief, which they can take in combination with regular Panadol and Nurofen. Most patients report back that they expected the recovery would be more difficult than what they had, and the vast majority of patients do not require the entire script of that stronger pain relief. For most patients undergoing breast reduction, the most important risk for them to be aware of is that of a post-operative bleed or hematoma. This typically occurs within the first 3 to 7 days after surgery, and it's most commonly caused because of the movement of the internal breast that's been moved around to create the new breast shape. So my most important advice for patients in their recovery is to plan not to do anything for that first week after surgery. Make sure that all of the meals, the meal prep has been done, that there's no jobs around the house. For patients that do have small kids at home, obviously you can't switch them off. So planning to have some support at home with you in that first week will ideally get you out of that window through which a post-operative hematoma can occur. And that risk is documented at about 1 to 2% of all patients having a breast reduction procedure. Here at the Coastal Clinic, our nursing staff would contact you the day after surgery just to check that you got home okay and there were no ill effects from the anaesthetic. And then we organise to catch up with patients each week back here in the rooms to take those tapes down, check the wounds, see how everything's healing, and reapply those tapes. During those post-operative nursing checkups, we would typically organise for you to have your post-operative lead light therapy sessions as well. All of the breast tissue that's removed is sent off to the pathologist, one, to check that there's no otherwise undiagnosed or occult breast cancer in situ. It also gives us the final weight of each of those sections of breast that's come out. And hypothetically, if you were to remove 50% of a patient's breast tissue, you would reasonably be reducing their own personal future risk of contracting breast cancer because they have less breast cells that have that malignant potential down the track. When I see patients back in my rooms around 6 weeks post-operatively, I often explain to them that the final outcome of breast reduction surgery won't be seen until about the 6-month mark. Obviously, we expect skin, breast, soft tissue to drop over time as things stretch out. So I warn patients preoperatively that immediately after your operation, the breast will feel like it's sitting very high and very tight on the chest because we're expecting that over the first 6 weeks, probably 50% of that stretch and drop and fluff will occur. I tell patients to expect the same amount of drop and fluff over the next 6 months. And then at that point, you'll have a very good idea as to what the final aesthetic outcome would be as well. Scar management for breast reduction is something that a lot of patients ask about as well. Here at the Coastal Clinic, we employ every scientifically backed way to reduce and optimize final scarring outcomes. And that starts in the operation with using stitches that dissolve over the course of 12 weeks, taping those wounds for 6 weeks after surgery, the use of the post-operative compression garment, the included post-operative lead light therapy that we have here at the Coastal Clinic. And then when I see patients 6 weeks after surgery, I give them their silicone scar gel and their silicone tape, and we talk about massage and ways to optimize what that final scarring outcome will look like. For most women that have jobs that involve desk work, computers, phones, I tell them that they should be comfortable to go back to work after about 1 to 2 weeks. Out of an abundance of caution, I advise them to take 2 weeks off work. Patients will often ask when they're able to drive after a breast reduction as well. For most patients, it's more of a case of when you feel comfortable not just driving, but slamming on the brakes or performing an evasive maneuver if required. For most patients, that would be somewhere after that first week. Returning to exercise or submersion underwater, be it in a pool or a bathtub or the ocean, typically advise patients to hold off doing any of that that until about the 6-week mark. Similar to having a broken leg, even if the pain was gone after 2 to 3 weeks, it doesn't mean you can start walking on it. And if you exercise, you are pulling the blood supply away from the skin edges. You may be bathing those incisions in even an imperceptible amount of perspiration, which of course will contain bacteria as well. So the smartest way to recover after a breast reduction is just to ensure that you minimize your aerobic exercise or any form of exercise for the full 6 weeks after surgery. And then when I see patients back in my room, they're typically given the green light to go back to whatever form of exercise they would like. One other commonly asked question is about nipple sensation after breast reduction. For all comers, the expected percentage of patients that will have loss or change of sensation to the nipple areolar complex after breast reduction is around 30%. Now, that's obviously particularly important for younger patients that have not yet had children and breastfed, because it may potentially affect their capacity to breastfeed after surgery. In general, for patients that haven't had children, around 70% of women will be able to breastfeed after breast reduction surgery, and around 50% of those patients choose to breastfeed after having breast reduction surgery. That was a bit of an introduction and overview of breast reduction surgery. If you'd like to discuss this procedure further with me, come and speak to me here at the Coastal Clinic.